Sir, good evening, sir. Shubham here, sir.
Good evening, Shubham. How are you?
I am very well, sir. How are you?
All well, चल रहा है हमारा. COVID,
Okay.
tough
I,
time
I
for
know, sir.
everybody.
How's COVID affecting your work, sir? Is it?
It has affected Shubham, but we continued throughout the pandemic. Oncology
Hmm.
services तो चल रहा है.
I know, sir.
बाकी एम्स में तो it was a major crisis because
Okay,
we are handling COVID also quite a bit.
okay.
Yeah.
But I realize, sir, in fact, in COVID, in our hospital, nephrology, matlab dialysis
हाँ
and
जी.
oncology were the two services which were running full stream actually.
Full stream. Yeah, absolutely.
And I realized that our volumes increased because there's a lot of patients who were going outside of the city now, sir. They stopped going. Matlab, there were so many patients who used to go to Bombay or elsewhere for treatment. They
Yes,
all
yes.
came back.
Absolutely.
So probably that is
And most of the other state hospitals are also closed.
also yes,
So they all are coming to Delhi and
all coming to Delhi, sir.
yeah.
That's true, sir.
So now I think we should be ready for more numbers in the next 3-4 months.
I know, I know, sir. I know. But I think people are. It's the I think the novelty of COVID has worn off, sir. Matlab, people are now ready to accept COVID. I
Yeah,
feel
yeah,
that way.
yeah, absolutely. Now the anger, denial, that
Yes,
phase is over.
that
Now they
phase is
are
over. Acceptance is there.
acceptance now.
Is there. Yes, I know.
So you
I know.
can see that attitude in the people also,
Yes,
and
I agree, sir. I agree.
but fortunately things are looking okay as of now in the last 1 month or so.
I hope, sir. I
So
hope they
if,
go. Yes,
if it stays like that, I think we'll tide over the crisis.
yes. So, sir, how we do it?
Hi. Yeah.
I have made you a co-host so that you can control your audio and video. Uh,
Okay. Okay.
we try to do a small quiz first. Dr.
Okay.
Shubham Jain, my namesake from Max Saket, is a co-host, sir, and he has prepared a small 5-question MCQ
Okay.
quiz
Okay.
related to chest wall tumors, just to keep the interest going on, sir.
Okay. Very good.
Then we move on to your topic. So
Okay.
what we try to do is we try to pick up questions from the previous year's question
Please.
bank, sir. So
Okay.
this is one
Okay.
of a short note. So we thought that
Okay.
this is how it started, sir, and it is now that we are trying to push it into a more organized format. So we are doing it every Wednesday.
Very good. Very
And
good. Yeah,
and
I've been following the topics. Yeah.
okay,
Yeah.
okay, sir,
Yeah.
okay.
Yeah.
So
Really good.
so
Good.
so
Good evening, Dr. Deo. Good evening.
Hi. Good evening, Dr. Geeta. How are you?
I'm good, sir. आप तो
Great. और सब ठीक. हाँ जी.
I think you said that COVID situation is getting better, no?
Yeah, looks stable as of now, but still fingers crossed.
Yes.
Yeah. अभी तो cases तो दिल्ली में भी कम है. AIMS is also, I think, it's stable, the
Stable.
numbers.
Okay.
Yeah. The duration is how much,
Sir,
Shubham?
sir, there's no fixed time, sir.
Okay, okay.
We love to have you for a longer time, but usually 45 minutes is something that the attention span is of a virtual
Yes,
platform.
yes.
And the topic is such that you don't expect a crowd. You have a small group of people with chest wall
Yes,
resections. So
absolutely.
it's just
Yeah.
the interested people who come.
Sure.
But the good part is, sir, that all this is recorded and available on YouTube on our channel.
YouTube. All
So
right.
it happens that if you want to create a short note later on, you can go back in, take a quick look, and create a short note for a reference.
Okay. So what I've done is, I think my talk maximum it will take 30 minutes. 30 minutes.
Okay. Sure,
A lot
sir,
of pictures are there.
Perfect. Sir.
So at the end of that, we'll see if there are any questions. Then we can wind up.
Yeah. No, sir. We'll be asking the most questions. Don't worry.
Sure.
It's a topic of our interest. Sir.
Yeah,
Sir,
great.
ठीक है. So, sir, it's 8:30.
Sure.
Okay, we'll start.
Yeah.
So just let me introduce and start the recording. Okay, all right. Good evening. Welcome. It's a Wednesday, 8:30 p.m. and we are back to Cancer Academy. So just like I will call it now a ritual that we are doing this every Wednesday, and we are very grateful to our national faculty who keep on obliging us and coming on this platform to speak to us and through us to a lot of interested students. And as we go along, the journey. The topics are becoming more niche and niche, and such is the crowd that the crowd is also now thinning out. Just like we and Dr. Dev were discussing that the novelty of COVID is wearing off, probably the novelty of virtual learning, virtual learning as we go back to our own routines is also wearing off. But we are here to stay and we are here to learn, and that is how this program is, and that is how this program will go on. Like I said to sir, that this is a topic which is close to my heart, so I expect most questions from coming from me myself. And sometimes these questions are the ones that I am afraid to raise hand in a crowd and ask Dr. Dev, but probably I'll type it here and allow Shubham Jain
All your
to
answers. Get all your answers.
allow Shubham Jain to ask for me. So the topic for today is chest wall resections and reconstruction. And Dr. Dev sir, I've had the good fortune of working for a short span of time under Dr. Dev's guidance, and during that time, I was very fortunate to see some of sir's magical cases. I'm sure sir will show those numbers. I don't know if sir will recall, but he did a total sternotomy, and we did a reconstruction with a PMMC overlying bone and cement graft, and that was the first one that I actually saw. So that is how the memories stick with us. This was back in 2011, I think.
11.
Yes. So
Long
before
time.
yes, long time. Yes. So before we go on, may I introduce our moderator for today, Dr. Shubham Jain, my namesake and my fellow colleague at Max Hospital, Saket. He's also a surgical oncologist like me, Dr. Geeta, sir, and he also has a very keen interest in thoracic surgical oncology, and he has prepared this quiz for us. May I now request Shubham Jain to please just switch on his mic and please come on board. Shubham, you will be conducting the quiz. Dr. Geeta will explain how we are going about the quiz. Dr. Geeta, please.
So for the quiz, do you have the slides with you?
Yeah.
So there is a number which is going to be flashed on the screen, and in that order you will be answering. So that is the number 9953621242. So now you can save this number for future also as the quiz master, so it becomes easy for you to answer. And then there is a format in which you have to send the answer. So you will write your name and institute name, and then put in your choices. Just put in your choices at whatever is the order. It could be 2, 1, 3, 2, 1 or whatever. Just put it in that order. Nothing else is to be done. So the number is 9953621242.
All right.
So go for it, Shubham Jain.
Shubham Jain.
Good evening, everyone. Thanks, Cancer Academy, Dr. Shubham, Dr. Geeta, and welcome, Dr. Deo. It's been an honor and privilege to have you with us here.
Thank you,
chest wall tumors and resections are something which are commonly seen in our surgical oncology clinics, comes forward in different forms to everybody. So this presentation, I'm just starting off with a few multiple choice questions that I could figure out on this, starting off with some trivia on this. So my first question is, who is credited with the first chest wall resection ever? I'm sure none of the participants would be able to take a guess on this, but the options are OCS, Emars, O.T. Claggett, Dr. Speroloro and Arnold, and McAfee and Associates.
So did you discover the answer while you were looking for it, Shubham?
Yes, for myself also, it was a discovery of the answer while I was preparing this quiz. The next question, which of the following materials is not suitable for chest wall reconstruction or stabilization? So synthetic mesh such as PMMA or PTFE or polypropylene, bioprosthetic materials such as alloderm or stratis, osteosynthetic systems such as stratos or metric strip, or all of them may be used. Fairly simple question. Next question. Which of the following statements regarding objectives of chest wall reconstruction is wrong? Restoration of chest wall rigidity and avoiding contraction of the chest wall is one of the objectives. To protect underlying mediastinal organs and prevent herniation of lungs, is that an objective? Prevention of paradoxical chest movements with respiration. And if trapping of scapula when resection involves 5th and 6th ribs is not of much consequence. Please note, you have to choose which option is wrong. Next question. So, which is the most common malignant primary chest wall tumor in adults? The options are osteosarcoma, chondrosarcoma, Ewing sarcoma, or plastocytoma. Coming to the last question. Can I have the last question? Yeah. So, in which of the following defects can a prosthetic reconstruction of the chest wall be avoided? The first option is resections larger than 5 centimeter but lesser than 10 centimeters in size. Defect spanning 4 or more ribs or involving the sternum. A large defect in the lateral or inferior anterior chest wall, or defects covered by scapula, even if the defects are quite large. These are the questions that are there, and I'd be happy to call on stage Dr. Deo to give his presentation and share his knowledge with all of us.
Thank you. Thank you, Shubham. Am I audible?
Yes, sir. You are audible, sir.
Yes, sir.
Yeah.
You can share your screen, sir.
Sure. I'll just do that. Yes. Yes, Shubham. I'm just doing it. Yeah. Got it?
Yes, sir. We can see it, sir.
Yeah. Good evening, everybody. At the outset, I would like to thank Dr. Geeta, Dr. Shubham, Dr. Shubham Jain, Dr. Shubham Garg for organizing this fantastic meet. And I was very happy when they offered me this topic because this is one of my areas of interest. And I would like to share general principles of chest wall tumors management. And I would also like to share our own experience in the Department of Surgical Oncology, AIMS New Delhi, and show different case scenarios, different challenges what you see in chest wall tumors. So we have a lot of pictures in this presentation. The first part I would like to cover the general theoretical aspect for the sake of postgraduates. So chest wall tumors. Chest wall, if you look at the anatomical structure, it's one of the most important structural and functional components of human body. The main functions being protection of vital organs like heart, lungs, and liver, and it also provides a flexible skeletal framework for the upper limb and neck movements. And we normally take it for granted, but if you see the chest wall movements, it is a very dynamic structure. It is not like a stationary structure. It's a respiratory movements on an average. There are 20,000 respirations per day. This is the average number. So we need to keep these factors in mind when you plan your reconstruction. And chest wall dysfunction can lead to significant life-threatening consequences. Indications for chest wall. If you see the general spectrum, not in the surgical oncology field, the broad spectrum includes congenital deformities, trauma, infections, and tumors. So what we'll focus today is on tumors. Prior to 70s, chest wall resections were associated with a significant morbidity and mortality to the tune of 30 to 40%. But the whole scenario has changed in the last 20, 30 years, mainly due to advances in the field of imaging. Now we have a better preoperative assessment of these patients, and we can do a better preoperative planning. Advances in anesthesia, critical care, surgical techniques, advances in reconstructive surgery, including flaps and prosthetics, and the advent of multimodality therapy. If you look at the broad classification of chest wall tumors, you can classify them into benign and malignant. And based on the source, we can classify them into primary, secondary, and metastatic. Primary tumors are the intrinsic tumors arising from the chest wall, either from the soft tissues or bone components. And secondary infiltration of the chest wall is also common, especially from adjacent organs like lung cancer and breast cancer. So they can spread to the chest wall and present like a Pancourt's tumor along with lung cancer, or sometimes you have a locally advanced breast cancer infiltrating chest wall. And you can also rarely encounter metastatic tumors of the chest wall coming from thyroid, renal cell carcinoma, breast, and lung. So basically, you should remember that the primary and secondary metastatic is little unusual in routine clinical practice. If you look at the spectrum and the frequency of chest wall tumors, they constitute less than 1% of all tumors in the among the adult population. And if you look at the thoracic malignancies specifically, chest wall tumors comprise 5% of the thoracic cancers. And in general, secondary involvement is more common than primary. And 50 to 70% of the primary chest wall tumors are malignant tumors. So almost 60 to 70 in most of the series, chest wall tumors are malignant tumors. In the pediatric case group, we have a specific type of tumors which are common, and the most common being PNET, also known as Askins tumor. And in adults, the most common malignant tumors are chondrosarcoma and soft tissue sarcoma. Secondary involvement generally is associated with lung and breast cancers. You can also classify chest wall tumors into benign and malignant tumors. You have a whole list of benign tumors, all soft tissue components, chondromas, osteomas, neurofibromas, lipomas, neurolemomas, and malignant you have either soft tissue tumors or bone tumors. Soft tissue is the usual soft tissue sarcoma classification. The similar kind of tumors you can encounter in the chest wall also. And the bone chondrosarcoma is the most common, followed by osteosarcoma, Ewing's, and you can also have deposits of multiple myeloma and bony metastasis. Clinical approach for the management of chest wall tumors. Once you do your clinical history and physical examination, performance status, comorbidity assessment, pulmonary function test assessment is critical, especially when you are planning complex and major chest wall resections. Principles of biopsy as far as chest wall is concerned, if you are dealing with a small and superficial tumors which are less than 3 centimeters, you can go for excision with margins. And if you're dealing with the deep-seated and large tumors, normally the recommendation is to go for a core biopsy for the histopathological evaluation and confirmation of diagnosis. Imaging plays a very important role in the diagnosis and planning of surgery. The usual imaging you start nowadays very few patients go for a chest X-ray. They straight away go for a PET scan or they come with MRI or a CT scan. But CT and MRI play a very, very critical role in the assessment of chest wall tumors and surgical planning. So what do you look for in these imagings? One is the lesion characteristics. A lot of hints you can get on the imaging, whether we are dealing with a benign tumor or a malignant tumor. Then the second important issue is the location, exact extent of the tumor spread, which part of the chest wall is involved. It is extrathoracic or intrathoracic, and how many ribs are involved, what kind of soft tissue involvement. So as a surgeon, you should be very, very critical when you analyze your CT scans or MRIs for chest wall tumors. And adjacent organ involvement, presence or absence of lung metastasis or pleural effusion is also needs to be looked at. So these are few imaging studies. When you see a CT scan of a chest wall, you can see on the left side is the soft tissue tumor in the posterior part of the chest wall. It's mostly replacing the erector spinae here and in the subcutaneous plane. So there's no intrathoracic component. The surgical approach for these tumors is totally different. When you come to the right side, if you see this is a bony tumor involving the rib, but sparing the soft tissues and intrathoracic component. Similarly, if you see on the left side, we are dealing with a large chest wall tumor, mostly extensive soft tissue component, both intrathoracic and extrathoracic, compressing the liver, you can see here. And on the right side, you can see a sternal tumor. This is the lateral view. You can see here the extrathoracic component as well as the intrathoracic component. So these assessments are very, very important when you plan your surgery, where exactly to enter the thorax, how much margin you need. So you need to spend a little while on the imaging before you plan your surgery. MRI has a specific role, especially when you are dealing with tumors which are located close to the spine or in the posterior chest wall. So here you have, as you see, it's a chondrosarcoma involving the vertebral junction here. You can see the part of the vertebra and the costovertebral junction is involved close to the foramina. So MRI will give a better delineation of the neural foramina, involvement of the spinal canal if there is any spread. So those things can be assessed before the surgery. Principles of chest wall resection: once you do your clinical and radiological assessment, the factors which can affect the chest wall resection include the performance status of the patient, whether it is a benign or malignant tumor, depth of involvement of the tumor, whether it's a full thickness chest wall or a partial thickness chest wall, extent of soft tissue involvement, adjacent organ involvement, and extent of skeletal involvement. It's pure ribs, ribs with sternum, or ribs with spine. So you need to assess all these factors. Coming to perioperative management, preoperative critical factors or assessments we have already discussed. Intraoperatively, we need to have a very good anesthesia team who are comfortable in putting double lumen tubes and epidural catheters. Analgesia is very, very critical in these patients. Postoperative ventilation, extubation strategies will depend on your quality of analgesia to the patient. Post-operative phase, elective ventilation facility should be available, a good analgesia, and chest physiotherapy is also extremely important. Types of chest wall defects. So how do you classify chest wall defects? It can be based on the extent of tissue loss. It's a pure soft tissue defect or a skeletal defect, or it can be a combination of soft tissue and skeletal defect. Depending on the thickness, it can be a partial thickness or a full thickness chest wall defect. Depending on the location, you can classify them into anterior chest wall defects, lateral chest wall defects, posterior chest wall defects, or a combination of these various permutations, whether anterior and posterior or lateral and posterior. Sternal defects, you can classify them into upper sternum, mid sternum, lower sternum, or a total sternal defects. So this is the anatomical classification of chest wall defects. Then you have a subset of complex defects. When you deal with chest wall tumors, sometimes you encounter patients with tumors involving chest wall along with limb girdle, chest wall along with diaphragm and costal arch, chest wall along with abdominal wall, especially the lower part of the chest wall involving abdominal wall, and chest wall along with vertebral column. So these are all junctional areas, a lot of functional significance. So this behavior, approach to surgery and reconstruction is different when you deal these subsites. I will show you some examples here. So type of chest wall defects, for example, on the left side, you can see this is a partial thickness chest wall defect. Only the soft tissue is lost. You can see the ribs are intact. And on the right side, you see a very complex chest wall defect where we have lost the part of the abdominal wall, part of the chest wall, and diaphragm is also sacrificed in this patient. You can see the liver and lung resulting in a single abdominothoracic cavity here. So this is a complex chest wall defect. So here your reconstruction strategies are totally different. This is a total sternal defect on the left side. You can see here. And on the right side, it's a full thickness chest wall defect. You can see the pleura coming into the pericardium and pleura coming into view. And we have lost a lot of skin here and a full thickness chest wall, including ribs and pleura. So how do you approach for these patients as far as surgical? I always insist the surgeon should be actively involved, not only in the planning, but when it comes to the operation theater, the position of the patient, the incision and surgical approach needs to be meticulously planned. Position will depend on the location of the tumor. Chest walls, either you can operate them on a supine position, lateral or prone, depending on your tumor location. Incisions and surgical approach, you need a good access for tumor resection and facilitate optimal reconstruction. You need to plan according to intrathoracic and extrathoracic spread. You have to be very, very careful. Sometimes you may see just the tip of the iceberg, a small tumor outside, maybe 3-4 centimeter, you can palpate, but there may be a 15 centimeter tumor in the intrathoracic area. So when you enter your intercostal space, you need to keep that in mind. So what is the intrathoracic spread exactly? So you need to keep a margin and go beyond that. So planning is very important. And always, most of the soft tissue tumors and bone tumor, they don't infiltrate the muscles of the chest wall. So always be careful when you do your thoracotomy. We try to save all the chest wall muscles whenever they are not involved. We try to dissect them in an anatomical fashion spare them because they will be useful for chest wall reconstruction. So mostly it is the principles of muscle sparing approach of thoracotomy should be utilized. Chest wall tumors, the principle is radical and pock resection with three-dimensional margins. The coming to margins, how much margin is adequate? You need to sacrifice skin or chest wall muscles if they are involved. For a low-grade tumors, normally around 2 centimeter three-dimensional margin is adequate. For high-grade tumors, it's around 4 centimeter approximately, depending on the feasibility. And when it comes to the rib tumors, the general principle, the general dictum is you take one rib above and one rib below. And when you're dealing with the primitive neuroectodermal tumors, it is recommended to remove the entire rib because these tumors can spread along the intercostal nerve bundle. So you need to remove the entire rib for a good clearance. And for approach to chest wall resection, you see on the left side, you have a tumor on the lateral chest wall. So we operate these patients in a lateral position. For sternal patients, we put them in a supine position. And also you need to be careful. You need to keep the shoulder girdles in the view, especially if you're dealing with a high sternal tumors. So you need to resect the clavicles also. So you have to keep the shoulder girdles in the operating field. Coming to aims of chest wall reconstruction. So what are the aims? When you plan, when you do a resection and when you start doing your reconstruction, you need to keep these goals in mind. First aim is to restore your chest wall stability. That's extremely important because if you remember my first slide, I have highlighted what are the important functions of the chest wall. Always keep them in mind. When you come back for reconstruction, it is not like building a rigid wall. So you need to keep all the functions in mind when you plan your reconstruction. So one is restore the chest wall stability, cover vital structures, protection, allow respiratory and limb movements. So when you do your reconstruction, keep these points in mind. It should be a water and airtight closure as far as possible. Obliterate dead spaces whenever feasible. Avoid flail segments. And good cosmesis is also one of the ultimate aims of chest wall reconstruction. So remember these 6 points when you start your reconstructions. Coming to principles of reconstruction, it is actually not I call chest wall reconstruction is a functional and dynamic reconstruction. It is not a simple anatomical reconstructions. You need to allow for positional change. You should imagine if the patient you are reconstructing in a supine position, in an operative position, if you don't allow for positional change in the post-operative period, the patient may get deformities. Prosthetic material, use appropriate size and tension. It should not be too tight or it should not be too loose. So also you should be able to visualize on the table how much laxity you want to give to that part of the chest wall when you do a reconstruction. And always cover the prosthetic layer with a layer of vascularized muscle or a good thick, good quality skin flap to avoid exposure and wound morbidities. Soft tissue reconstruction, your options are primary closure, local advancement, rotation advancement flaps, breast flaps, myocutaneous flaps, segmental flaps, free microvascular flaps. So we have a whole range of flaps which can be used, but we always go for the simplest option whenever feasible. Then we go to complex options. It's called the step ladder approach. So these are the muscles you should always remember. They will be very, very useful in any chest wall reconstruction. The most important being the trapezius, latissimus dorsi, external oblique, serratus muscle, and pectoralis major, and rectus abdominis. So whenever we plan these surgeries, I go layer by layer. Once you do your skin and subcutaneous tissue, then we harvest these muscles, preserve them in an anatomical fashion, then we enter the chest wall. Of course, if they are grossly involved, they should be sacrificed. Skeletal reconstruction, any large defect more than 5 centimeter in diameter or loss of more than 4 ribs or sternal defects, you should always do the rigid reconstruction. Otherwise, simple soft tissue reconstruction is also adequate for managing chest wall defects. Just remember these 3 points: large defects, that means more than 5 centimeters, loss of 4 ribs, and sternal defects. The traditional options for rigid reconstruction include bone grafts, cartilage, various materials have been used. If you see the history of chest wall reconstructions, you will see they have used steel wires, metal sheets, fascia lata, Avalon sponge, Teflon grafts, a lot of material has been used. So, but what is the ideal material if you are planning for a rigid reconstruction, chest wall reconstruction? So, what are the qualities of an ideal prosthetic material? It should be rigid to avoid paradoxical movement. It should be inert to just to allow ingrowth of the fibrous tissue. It should not react with the surrounding tissues. It should be malleable to facilitate contouring of the chest wall. It should be radiolucent, so it should not interfere with the imaging, and it should be widely available and affordable. So what are these synthetic material which can be used for rigid reconstruction? The most commonly used material are synthetic polypropylene mesh, either a Marlex or a Prolene mesh. Gore-Tex patch, PTFE patches can be used. You can also use composite mesh, which is a combination of Prolene and Vicryl. Bone cement, that is polymethyl methacrylate, can be used for rigid reconstruction. And we have a biological mesh, which is bovine pericardium or ADM. And we also now have available synthetic neoribs. And the state of the art is custom made 3D printed material for rigid reconstruction. We use titanium for 3D printing. So what are the advantages of synthetic mesh? It's a low cost, widely available. We have extensive experience in using it in general surgery. It is inert and allows ingrowth of soft tissues. It has a good tensile strength, and you can do layering of the mesh. You can also contour the mesh. You can also sandwich, in the sense you can use bone cement, which can be sandwiched between two layers of mesh, and it is malleable. It is easy to fix with the ribs. So that is why the most popular material is a polypropylene mesh. Bone cement, it gives extra strength, rigidity, protection of vital structures. Contouring is very possible using bone cement. And there are certain disadvantages with bone cement. You should remember, it can cause exothermic reaction. It can cause metabolic acidosis on the table, mechanical failure and fracture in the long term, exposure and infection. So we use it sparingly. I will show you some cases where we routinely use bone cement. So this is one of our cases where it's a large anterolateral chest wall defect. We prepared the bone cement on the table, and you can see here on the left side, we sandwich the bone cement between two layers of the mesh, and I also contoured this mesh. You can see here. So this is contoured because it's a lateral chest wall. We can give a shape to the bone cement, and always keep these extra edges of the mesh, extra edges, because we try to avoid fixing this bone cement close to the bony structures, because there will be a lot of friction between that. So we use these edges of the mesh for fixing and keep a little bit of sling sort of thing, so that it will move along with the chest wall. And morbidity and mortality coming to chest wall resections, as I told earlier, it has now the results are fantastic. In the 70s, it used to be 20 to 40% morbidity if you see the old literature, but now it is less than 5%. Mostly pneumothorax, hemothorax, flail chest, pulmonary complications, respiratory failure, wound morbidity, and prosthetic failure. Mortality is extremely low if you handle these patients carefully. Current mortality is less than 1%. So what is the role of VATS? It's coming up recently as a diagnostic tool and also as a therapeutic tool. Advances in VATS technology and instrumentation is now enabling surgeons to resect benign tumors and small chest wall tumors using VATS. And the usual advantages of early recovery, less pain, reduced hospitalization, and cosmesis. Difficult subsides we have already discussed. You see, this is the sternocostal junctions along the shoulder girdle, vertebrocostal junctions, and abdominothoracic junctions, subcostal arch. So thoracoabdominal defects, how do you manage thoracoabdominal defects? It's a very complex and challenging problem. Whenever you end up resecting the diaphragm or costal arch, the aim of reconstruction is to separate the thoracic and abdominal cavities, and also to reconstruct the diaphragm and costal arch. So you need to keep these things in mind. So we have various options. If it's a very low chest wall resection, what I do is we shift up. If you're resecting 11th, 12th, or 10th rib, I do the resuspension of the diaphragm using the 10th rib or 9th rib. So you will not lose much of the intrathoracic space, but you just get anatomical sort of a reconstruction. So diaphragm is detached, you do the resection, and you reattach the diaphragm with a higher rib. If you are resecting 12th, 11th, or 10th, you go back to the 9th and reattach it. But if you are doing a good amount of that part and costal arch, sometimes we use synthetic material as a costal arch, either a titanium plate, or sometimes I use a rolled up mesh. You just roll the mesh and you can contour it like a subcostal arch. Tumors involving the shoulder girdle and involving chest wall are also very, very challenging. A large girdle sarcoma sometimes can infiltrate chest wall, and most of them end up with a radical 4/4 amputation because they also have gross neurovascular invasion in most of the cases. And this is one example here where we ended up doing a radical 4/4. This was infiltrating chest wall. The axillary vessels were also encased. So this patient ended up with a chest wall resection and a 4/4 amputation. Combined chest wall and spinal defects is again very, very challenging. We normally do a team approach using along with neurosurgeons, and we give them a transthoracic approach after resection of the tumor. It can be single staged or it can be a stage resection, multi-stage resection. Posterior approach can be used, or sometimes we have also tried lateral approach, transthoracic with the hemivertebral resections. These are very little difficult because most of the neurosurgeons are used to a prone position for vertebral surgeries. So we tried some lateral position also, and spinal stabilization normally we use interlocking plates or Harrington rod. So this is one of our patients where he had a chondrosarcoma, if you can see here, involving the vertebral body and costovertebral junctions. You can see on the right side in the bone window. So this patient we operated in a lateral position along with neurosurgeons. We did a chest wall resection. We gave the exposure to the vertebral bodies. Then hemivertebrectomy was done in this patient. We lost 3 vertebral bodies, and you have to be really careful in these patients. And we did a fixation along with the titanium rod here, spinal fixation, followed by chest wall reconstruction here. And you see the muscles we try to preserve while doing a thoracotomy and cover these defects. Role of neoadjuvant chemotherapy in chest wall tumors. Yes, it has a role. In the subset of tumors, that is Ewing sarcoma or Askins tumor, they are very, very chemosensitive. And when you are dealing with primary osteogenic sarcomas, rhabdomyosarcomas, or lymphoma of the chest walls, so that is where you use neoadjuvant chemotherapy. Askins tumors, a few words, because you do come across these tumors in tertiary care referral centers. This is a rare aggressive tumor affecting younger population. The characteristic features are it's a small round cell tumor, IHC positive for neuron specific analysis, and they can also show chromosome translocation between T11 and 22. The main treatment for this Askin tumor patients is multi-agent chemotherapy. Most of them we start with neoadjuvant chemotherapy, VAC and IE, alternating weekly regime. And after 9 to 12 weeks of chemotherapy, usually we do the assessment for resectability, then go ahead with surgery, then followed by further chemotherapy, complete the whole course. And sometimes we do also give radiotherapy. So the chemotherapy and multimodality management has made a dramatic impact on the outcomes of Askins tumors. Now currently the survival rates are for 30 to 40%, which used to be less than 10% before the advent of systemic therapy. These are few of our cases of Askin tumor. You can see they generally have a huge soft tissue component on the left lower chest wall here, pushing the spleen. And on the right side, you can see after 9 weeks of chemotherapy, there's a significant reduction of the tumor volume. This is another patient, a huge intrathoracic component with lot of necrosis. You see extrathoracic is very, very minimal, just 5% is extrathoracic and 90% is intrathoracic. And see the dramatic response with the neoadjuvant chemotherapy. On the right side, you see this the residual tumor. So we went back and did a chest wall resection in this patient, followed by radiotherapy. So coming to our own experience in the Department of Surgical Oncology, AIIMS New Delhi, we have around 152 chest wall resections. I think this data is till 2015. That's what when we last updated. Now it is crossing 200 plus chest wall resections in our department. It comprised around 1.3% of surgical oncology cases and 15% of thoracic oncology cases at our center. The mean age of our patients is 39 years, predominantly male, almost 84 versus 66. Primary chest wall tumors were the most common in our experience. 64%, that is 99 tumors were primary chest wall tumors, and secondary chest wall tumors, we operated around 51 patients. And miscellaneous spectrum, I will show you one or two cases. They are non-malignant chest wall conditions. Primary chest wall tumors, out of these 99, 75 are soft tissue tumors and 24 are bone tumors. Out of the 75 soft tissue tumors, around 92% are malignant soft tissue sarcomas. Only 6 were benign. And among the bony tumors, cartilaginous tumors, almost 80% were malignant tumors. Profile of tumors, if you see in the soft tissue sarcoma on the left, we have a whole spectrum of soft tissue sarcomas involving the chest wall, the most common being the DFSP, MPNST, MFS, and synovial sarcomas. And the most common malignant tumor is chondrosarcoma. That is almost 19 patients had chondrosarcoma. And we also had certain benign tumors like osteoidostoma, aneurysmal bone cyst, GCT, 1 case each. Secondary chest wall tumors, we had to resect chest wall in 51 patients. For a carcinoma lung in 22, for a carcinoma breast, recurrent breast cancer infiltrating chest wall, we had around 21 patients, and some skin cancers also we have operated which were involving the chest wall. And we had 2 patients of post radiotherapy osteomyelitis and post sternotomy dehiscence. I think these 2 also were operated in our center. So our approach to chest wall management, we offer surgery alone for benign tumors or low-grade tumors, surgery along with chemotherapy in all PNETs, and especially for secondary lung tumors, carcinoma lung, carcinoma breast, they always come back after chemotherapy. Adjuvant chemotherapy is generally recommended for high-grade soft tissue sarcomas and also in Ewing's tumors following resection as adjuvant for completion of 48 weeks of chemotherapy. And for radiotherapy, our indications are any margin positive resections or high-grade malignant tumors, and when you are dealing with lung or breast cancer, secondary infiltration. Our mean number of ribs resected in our series is, the range is 2 to 8 ribs, and the mean number of ribs is 3.5. The mean defect size was around 13 square centimeters in our series. Extended resections were required in 33% of patients, lung in 32, diaphragm in 7, vertebrae in 5, vascular resections including SVC into mammary artery in 6 patients, and pericardium in 1 patient. Coming to reconstruction, we had a whole spectrum of muscle flaps, the most common being latissimus dorsi, serratus, pec major, and rectus flaps. And rigid reconstruction, we have used bilayered mesh is the most common type of rigid reconstruction we use. That was used in 65 patients, and tri-layered mesh in 10. We use vicryl mesh towards the lung inner side and put a bilayered Marlex mesh outside so that the adhesions are less with the lung. And we used bone cement along with mesh in 5 patients. And subcostal arch reconstruction was performed in 5 patients, titanium plate in 2, and rolled up mesh in 3. Surgical outcomes, the mean operative time is around 4 hours in our series. Mean hospital stays around 8 days nowadays. ICU maximum, most of these patients stay for a day there. And morbidity is approximately 10%, and we did not encounter any mortality in our series. The relapse patterns, if you see the chest wall dissections, the chondrosarcoma, they do well. Majority of the intermediate and low-grade sarcomas, we had around 10% relapse, including local and systemic. Soft tissue sarcomas, the relapse rates were 20%. Lung and breast secondary tumors, we had around 25 to 30% relapse, mostly systemic, you can see here, and around 5% local recurrence. And PNET, that is Atkins tumors, around 50% relapse. That is the worst kind of tumor because of the aggressive nature. We had around 50%, mostly systemic relapse. Now I'll show you some of the cases which we operated, starting from a surface chest wall tumor involving the lower chest wall and abdomen. We keep all these muscles intact. When you plan these resections, you can see the muscle mapping done here. And this is a large soft tissue defect, fortunately not a full thickness defect. So we do reinforcement with a mesh because his muscle was very thin, and we used a latissimus dorsi flap to cover it. This is another interesting patient who had a chest wall resection 10 years back, followed by radiotherapy also. Then he presented with a recurrent tumor. You can see here, he had another recurrence here. We went back for a resurgery. We did a wide excision and a brachytherapy because he already had a axial beam radiation. And we used a flap, latissimus dorsi flap for reconstructing the soft tissue defect. This is another interesting patient who she presented with the angiosarcoma of the chest wall. You can see here on the left side a huge tumor. So here, if you see the resection, we need to remove a good chunk of abdominal wall also, lower part of the chest wall. You can see the diaphragm here, and she lost almost 7 or 8 ribs to get a clear margin. And she also had a lung metastasis. On the intraoperatively, we found one lung nodule, and we did a metastectomy at the same stage. So this patient we reconstructed with a bilayered mesh sandwiched with bone cement, contoured mesh, and over that we use the latissimus dorsi. You can see the muscle normally you can see here. It is harvested in the stage of before entering the thorax, and we covered the entire mesh. See here on the left image, the entire prosthetic material is covered with a good vascularized muscle, and this is after the closure. This is the subcostal arch reconstruction. You can use a titanium mesh, a titanium plate, and over that you can use a synthetic mesh to reconstruct the chest wall. So the mesh is used to reconstruct the chest wall, and titanium plate is used to reconstruct the subcostal arch. This is, I think, the chondrosarcoma of the sternum. You can see the MR image on the right side. It has a huge interthoracic component also. And this is a subtotal sternectomy defect with the pericardium and lungs which are exposed here. So we do a bilayered mesh closure, and you can see the pec major is preserved in this patient. I'll just show you the next picture, how nicely the pec major can be brought into just to cover the entire synthetic mesh. You see here on the left side, the pectoralis major is used here to cover the synthetic mesh, and this is after the skin closure. Another patient with sternal chondrosarcoma involving the sternoclavicular joints here. So we ended up doing the subtotal sternectomy along with the resection of first rib, second rib, and bilateral clavicles here. You can see the internal mammary artery being looped here, and we are going to resect the upper part of the tumor in this picture. So this is the defect here, including the clavicle cut ends are here. So this is a challenging reconstruction because what happens, the entire shoulder girdle opens up because you are resecting the clavicles. So the just sort of a diastasis of the shoulder girdle takes place. The scapula falls back. So you need to have good rolls under the shoulders. When you do your reconstruction, you have to be very, very careful. If you don't keep the shoulders in neutral position, you really don't know how much to fix between these two clavicles. So this is the kind of position you have to have on the table. So you see here what we did, we rolled up the Marlex mesh here, and we joined with the cut end of the clavicles on both sides, and it is contoured. And we also used sandwiched bone cement here to protect the pericardium and the great vessels in the precordial area. So this mesh has been used to reconstruct the shoulder girdle. Along with that, the protection of the pericardium and great vessels. And see, again, we use pectoralis major is nicely coming to cover the entire synthetic mesh. And this patient, you can see, we also gave postoperative radiotherapy to this patient. You can see the radiation field markings here, and you see the shoulder girdle and the shoulder movements are intact postoperatively. So this patient is now almost 10 years, I think, in the follow-up is doing well. Another challenging case, you see, this patient was diagnosed as some breast cancer in some OPD, then not in our hospital. They were thinking it's a breast cancer. Then when she came to our center, when we did the workup, it's basically a chondrosarcoma of the chest wall, pushing the breast towards outside. You can see here on the CT scan, it's a huge chondrosarcoma with a large interthoracic component and or extrathoracic component. This is a three-dimensional reconstruction of the same patient here. You can see the extent of the tumor involvement. So again, thoracoabdominal approach here. We did a lower chest wall resection. Part of the liver was removed and part of the lung was also infiltrated. So that needed sacrifice in this patient. And what we did in this patient is we used a subcostal arch reconstruction. Then we did a chest wall as well as abdominal wall reconstruction using a bilayered mesh, which was covered with a adjoining muscle, and a TA flap advancement was done. You can see this is the abdominal flap. Fasciocutaneous flap was mobilized to achieve a soft tissue closure, skin closure. This is, I think, one of the interesting cases. I don't know whether the young generation of surgical oncologists are seeing these kind of conditions. This is a post-radiation osteoradionecrosis. We see once in a while. In the current modern radiation oncology field, we don't see these kind of complications. But once in a while, we come across this patient. This patient had a severe radiation-induced osteoradionecrosis, and they have whole chest wall was like melting like butter. So we managed conservatively for a while. You can see the CT scan here, the entire sternum, multiple ribs. It was in a very bad condition. So these here, the principles are different. You don't do like a tumor resection. Here you go for a staged sort of a debridements, clean the tumor bed, get a good healthy tissue, then go for resection and try to avoid entering the pleura whenever possible, because you will be infecting the entire pleural cavity. So the principles of managing these kind of conditions is slightly different from the principles of managing chest wall tumors. Yeah, so finally we went back, I think in this patient for surgery. I was planning a rectus flap with a chest wall resection here, and we managed with the TA flap closure. So coming to just the review and comparison of chest wall series which have been published from various centers in the West along with our series. You see, most of the time chest wall tumors, you don't find very big series like 500 patients or 1000 patients. It's mostly 2 digits or 3 digits. So these are certain publications from MD Anderson, Taiwan, Emory University, Italy, National Cancer Institute, and NCI Italy. So the spectrums was quite heterogeneous. That's what I wanted to highlight here. So 50% of the tumors in this series were benign, 50% of the tumors are benign, 35% are infections. In the Italian series, 50% were benign, 50% were malignant. So that's why you cannot compare chest wall tumors like breast cancer or lung cancer. So first you need to look at the spectrum of the disease in that series. Whereas in our series, out of 152, 95% are only malignant tumors because we work in a surgical oncology setting, and our operative mortality was 0 and survival was around 65%. So this, I think, will sum up. So this is, I think, the future of chest wall prosthetics. Now we have 3D printing coming in a big way. We tried in one patient the sternal printing. So this is a picture from my Australian case. So you can do a 3D contouring of the entire defect, plan it, feed your CT scan data, and you can do a printing of the exact contours and exact size of the rigid reconstruction material using titanium. So this is the future of chest wall prosthetics. I think in the next 5 years you will see a lot of this. I think with that I would like to end my talk. Thank you. Thank you, Subha.
Thank you, sir. Thank you so much. So I'll request people to put some, if they have any questions. We have very senior faculty like Dr. Subramanyeshwar Rao and Dr. Manomoy Gongle here with us. So if somebody wants to chip in or would want to just share the experience, we'll be very happy to have them, because it's not very common that we have and so many people, senior people with us. So if anybody wants to join in, we'll be very happy. There are some questions, Shubham, which actually me and Shubham have put, and these are the things that were coming to our mind when we were listening to your lecture.
Hmm.
Shubham, you will take up
Yeah,
those
yeah.
questions for sir, please.
Yes, I would. I would request first Dr. Subramanieshwar or Dr. Ganguly to have the comments, if we could have them.
So
Dr.
you
Rao,
can
sir.
unmute yourself, Dr. Subramanieshwar Rao. Sir,
Yeah,
Sir, good evening.
good evening.
How are you,
we
sir?
will never miss when you talk.
Sir, we are fortunate
Because
to have you.
it's your hard work, endurance, and performance at the highest level. Always learn from you. Now, I was surprised that
Sir.
there was no microvascular flaps reconstruction.
Yes, sir. Yes.
Amazing work, massive resections. I think that will give you confidence to the younger ones.
Yeah.
But microvascular is something that would have been also very useful, is it not?
Absolutely, sir.
Especially
Absolutely.
the ALT is a very good
Yeah.
tissue. Yeah.
Yeah, absolutely. I think that is especially when you don't have when you're dealing with the recurrent tumors, when you're losing the normal chest wall muscles, free flaps are the first option. That's what we use, sir. In our series, fortunately, we have managed most of these patients without a free flap.
Correct.
Yeah.
It decreases the expenditure. There's no doubt about it.
Yeah.
But you, if you have a good microvascular surgeon, I think it takes the pressure off you because all the
Absolutely.
options would be open.
Absolutely, sir. Absolutely. I fully agree with that.
Just wonderful.
Should I say something?
Yeah,
Hi,
sir.
Dr.
hi,
Ganguly?
hi, Dr. Ganguly.
Hi,
Good
good,
evening.
good talk. Good evening.
Thank
As
you,
you
thank
know,
you.
soft tissue sarcomas has been one of my areas of interest also.
Great, great.
So anyway, we have done a lot of work ourselves, both when I was doing my MCH in Cancer Institute Adyar, as well as, of course, in the army for
Yeah,
about 20, 30 years. So
absolutely.
in Adyar, it used to be a practice to give preoperative radiotherapy 40 grade to all these tumors and then resect them. So that would cause a bit of sterilization of the margins when resecting and prevent seeding. So that
Yes.
was, of course, a practice which we didn't follow in the army. So I've also had my share of soft tissue sarcoma dissection of the chest
Absolutely.
walls, and we
Yeah.
used to use a lot of the meshes that you have described.
Yes.
One of those particular meshes, I forget the name, used to be a bilayered mesh with one side. It was, I think, from Johnson and Johnson.
Yeah,
The
yeah,
inner
yeah.
part used to be, totally.
Vicryl, I think.
No, it wasn't
Vicryl.
vicryl. It wasn't propellant. It wasn't vicryl. The inner part used to be totally like a muscle, I would say. A smooth. So I've used it in a number of cases where it basically allowed that there would be no ingrowth or
Additions.
additions with the underlying
Additions.
organs.
Yeah, proceed
Prosop,
mesh, I
prosop,
think. Proceed.
prosop.
Uh,
Proceed.
Yes,
no,
yes.
I think it is a different name. Anyway, so
Yeah,
we've used a few of those. So these are just, I thought, things that I would share. That
yeah.
one thing when you have to have a large tumor and you want to be sure of no seeding thereafter, one could use preoperative radiotherapy as used to be the protocol in Cancer Institute routine. And another, of course, we have been using these particular meshes where we managed to get away with good reconstructions. And
Absolutely.
we really didn't need to use microvascular, as
Mm-hmm.
my other good friend Subramanieshwar
No.
was mentioning just now.
Yeah, yeah,
So
yeah.
anyway, good talk, good series.
Thank you.
Well
Thank
done.
you.
Thank
Thank
you,
you.
sir.
Okay.
Dr. Vani is also here with us. Dr. Vani, ma'am, you want to come in actually? So I have actually having breast cancer with so deep invasion involving the chest wall is not something very commonly that we see. Although sir has shown some beautiful cases. So if madam wants to come in. Uh, but sir, my question is
Yes.
that in the past, the series that you showed in 17 years, you had 152 cases, which makes it 10 cases a year, right?
Yeah, yeah.
And
Approx.
with the volumes that you have, I am lucky to do, one case in 2 months, and I feel that I am lucky that I'm able to do that. So, my question is that how do we how can we then collate all the experience and get something good out of it, because I what the numbers that you showed and all of there, there are no good.
Yeah, absolutely.
There's all just retrospective series. We don't get any good data to fall back on.
Yeah, absolutely, Shubham. That I fully agree, because this is chest wall is actually a sort of a confluence area. Different centers manage a different spectrum of disease. There are general thoracic units, there are surgical oncology units. I've seen the series coming from different units, and unless you maintain a prospective clinical database, it's very difficult to gather all the information, especially the kind of resection details, reconstruction details. It needs to be captured prospectively. So we have been maintaining, I think we are now crossed 220 cases, because this is till 2015. With the advent of more imaging and more referrals, I think the volume will be definitely more, especially mostly seen in tertiary care cancer centers. I think pooling of data is going to be very, very critical. I think if the major centers, around 8 to 10 centers in India pool, I think we can easily almost touch 1,000 cases. That's what my guess,
I
which will
agree.
be fantastic for a chest wall tumor data.
I agree.
Yeah.
Shubham, you want to take those questions, please?
Sure, I'll be happy to take those. So, sir, it was a very interesting series that you had presented.
Thank you.
Very
Thank you, Shubham.
exhaustive.
Thank you.
Just some of the questions that have come across on the chat is
Yes.
that what are your anesthetic preferences? Do you ask for single lung ventilation for most of the chest wall resections, or how do you prefer that?
Uh, a single lung is not mandatory, Subham, for all cases. It depends how much tumor you are removing. If it's a predominantly extrathoracic tumor, if your anticipated entry into chest wall is not significant, you can just manage without a double lumen tube also. But if you are dealing with a large intrathoracic component tumors where you need to enter and remove more ribs, then we go for a double lumen tube. And during fixing the mesh, you can do, if you are doing a single lung, is not a problem. But if you are ventilating both the lungs, sometimes we ask our anesthetist to keep the tidal volume little low, so that the lungs will not come into your field. So it is
Okay.
not mandatory, but it depends on the type of case you are operating.
Okay.
Yeah.
So you also mentioned about the use of VATS into these complex surgeries. So how frequently do you use VATS to assess the intrathoracic extent or spread, or where to take the cut in from the intrathoracic side?
Yeah, that's actually, you see, Subham, mostly we were using imaging related data. Our thoracoscopy work has started late. Dr. Sunil does most of the thoracic oncology work. We use thoracoscopy for intrathoracic assessment. And the last 1 or 2 years, we started assessment of these cases. But majority of our cases, because imaging is so accurate, you can easily plan your thoracotomies based on the imaging. But if you have a routine thoracoscopy program, you can always, there's no harm in putting a scope and see the intrathoracic extent.
So going forward for the younger members in the audience, you would
Yes.
definitely recommend a VATS assessment if
A
feasible.
VAT assessment is not mandatory. That's what I'm telling. If you have,
Okay.
if somebody is not experienced, or if somebody does not have a facility, imaging analysis is very, very important. A good
Okay.
CT scan or MRI will give you a very good accurate picture of intrathoracic spread. How much is the
Okay.
volume?
Okay.
Yeah.
Sir, you had shown how you used bone cement for replacing sternal defects.
Yes.
So one question that we had on the chat box was, how do you contour the bone cement to the native chest wall
Yeah. Yeah.
when you don't have
Yeah.
3D
Absolutely.
printing or
Absolutely. I think
something?
that's a very good practical question. Even I was wondering when I started our work. So what I used to do, contouring is important when you are dealing with the defects in the anterolateral chest wall, where if you don't contour, what happens, you lose the thoracic volume. If you try to fix the mesh edge of the rib to the edge of the rib, the contouring is not there, you lose intrathoracic volume. The second area where I need contouring is the upper part of the sternum. If you don't contour the mesh, what happens? The upper edge of the mesh sometimes can cut the trachea. You got the point? Because if you don't
Okay.
contour it,
Yes.
so it happened. I've seen 1 or 2 patients, not in our series, the upper part, the edge after sternal resection, they did not contour it. It was actually abutting the trachea. So slowly it eroded the entire trachea. So these are 3 or 4 critical areas I do the contouring. And the contouring, how I do it is I use a malleable retractor first. So I do a malleable retractor, take a malleable retractor, I do the shaping using the malleable retractor, then bring the malleable retractor out, and over that you can contour the bone cement. You have the curvature of that, then you put your bone cement between the mesh and just put it before it sets in over that malleable retractor, and you can give a curvature to it.
Okay, that's
Yeah,
a very useful point, sir.
yeah.
And for diaphragm reconstructions or substitutions, what
Yes.
is your preference with regards to mesh versus something more
Yeah,
sturdy?
Shubham, what we do if your diaphragm loss, you see there are two situations we can have. One is just detachment of the diaphragm. The other is loss of diaphragm. Okay, so if simple detachment, we have a normal diaphragm which is just detached from the rib, because you are going for a margin of the lower rib margins, then you need to detach it, but you don't have to resect it. So in those areas, I don't try to use a mesh again to augment the diaphragm. The remaining diaphragm we try to suspend with a subcostal arch or a rib which is higher up. Up to ninth, eighth rib, I'm comfortable. Beyond that, I don't like to go up. Then we do a subcostal arch reconstruction. If you end up resecting the diaphragm, then we use normally the proceed mesh or a bilaid Marlex can also be used.
Okay, and how do you contour that to the curvature of the diaphragm, sir?
It's actually contouring is difficult. It will be suspended from the rib or suspended from the costal arch. So it will take a shape according to your suspension.
Okay.
Yeah.
And
Yeah.
you were mentioning about your experience with the tumors of the lung cancer and the breast cancer.
Yes.
What is your preferred neoadjuvant approach for those? You mentioned about radiotherapy as the adjuvant.
Yes, Shubham. I think breast and lung, the standard neoadjuvant protocols are used. The what you use for lung cancer, especially the PANCODES, CT, RT protocols, or for the breast cancer also the same, the standard neoadjuvant protocols which are used. They're not different. The standard protocols which are used for breast cancer and lung cancer are used for the same.
And as for bone sarcomas, many surgeons prefer to use the pre-neoadjuvant chemotherapy margins.
Yes, yes,
I know
yes,
the physiological considerations in the chest walls are
yes,
remarkably different, but in
yes.
your experience, coming to the post-NACT margins, has it compromised the outcomes in any way?
Shubham, here you see most of the common bone tumor, malignant bone tumor of the chest wall is chondrosarcoma, which is not chemosensitive in adults. So
Okay.
there we don't use neoadjuvant. Only most of the neoadjuvant experience we have is the Askins tumors in our series. So there, I think it's a standard protocol we use. At sterilization, after shrinkage, the margin we assess the residual tumor and the entire rib, which is grossly involved. That's what we target after downstaging of the tumor with chemotherapy in Askins tumor. The rib needs to be resected, because if you see these tumors after shrinkage, you see a residual thickening of the tumor along the rib, sometimes going back up to the sternovertebral, costovertebral junctions. So you should not miss that. And you can also have thickened pleura post chemotherapy. So all the diseased soft tissue also needs to be removed. PNETs and Askins tumors after chemotherapy, you need to see for the imaging how much is the shrinkage, and along with that, any abnormal soft tissues surrounding the tumor also we remove.
Okay. Another question that we have is, with the prosthetic materials that are available and they being fairly expensive,
Yes.
especially to the Indian population, what has been your experience? Have you ever used titanium mesh instead of bone cement, or the newer modalities of osteosynthetic uh, prosthesis available?
Rigid plates, you see, titanium mesh we use for mostly craniofacial reconstructions. Chest wall, we used titanium plates, which are used for the mandibular reconstruction. If you remember, simple titanium plates, they cost around 15,000 rupees. There are some Indian products also now available for 7,000-8,000. The titanium plates can be used as a replacement for subcostal arch. Titanium mesh we normally don't use for chest wall. We use for craniofacial resections and other.
Okay. Another question that we have from the audience, sir, is, in case of huge phyllodes tumor, what is your reconstruction plan of choice?
That depends what exactly you are losing, how much skin, how much of soft tissue, and how many ribs. So if you are ending up with a through and through chest wall defect along with the breast skin, if no flap is available, we have two options. Either if you, because phylloides, if you're dealing with a moderate prognosis group, you can go for a rectus-based flaps. They are good. For the rigid reconstruction, we use bilaid mesh, and we can use a rectus-based flap or a latissimus dorsi flap.
Another question that we have in the audience, sir, is even for benign tumors that are locally recurrent, what is
Yes.
the margin that you would recommend? And would you recommend radiotherapy for such tumors?
A pure benign tumors, as such, the radiotherapy recommendations are not very strong, but we go if they are coming back, that we normally keep a margin of at least 2 centimeters for these tumors. And radiotherapy, strong indications in chest wall. We have to be careful, especially radiation of chest wall, especially with the synthetic material in place. Long-term morbidity is the issue. Unless there's a strong recommendation for adjuvant radiotherapy, we try to avoid it, because
Okay.
post long-term wound morbidity is going to be high if you give radiotherapy in these patients.
And one of the last questions is, how do you place the rigid part of the bone cement mesh complex? Do you underlay it in the thoracic cavity, or do you overlay it outside the thoracic cage?
I normally suspend it. I neither overlay nor underlay. What I do, you see, both are dangerous, because if it is the bone cement is abutting the rigid chest wall, every movement of the chest wall, there will be a friction between the bone cement and chest wall. So my principle is different. What I do, I suspend it in the air. Okay, it is not touching any part of the rigid bony wall. It is like a
Okay.
hammock.
Okay.
It's like a hammock. So the rigid part is in the center, and the edges of the mesh, they get connected with the ribs. It is neither inlay nor outlay. So I suspend it
Okay.
in the middle of the defect so that there is no interaction or friction between the bone cement and the ribs, because that will cause long-term
The
problems.
problem that we
Yes.
face, me and Shubham, is
Yes.
when you have to be very exact with the size of that to suspend it in that defect. Otherwise, especially if you have to do a contouring also, and if you
Yes.
have to do the sizing also. Otherwise, what happens is that even if one of the edges
Yes.
gets larger
Yeah,
than
absolutely.
you can't
Absolutely.
change that. You have to
Absolutely.
completely change the whole mesh. So that
Ab-
is
Absolutely. So that's what I'll give a tip, Shubham. What I do, I once I do the resection, I keep the patient in a neutral position. You
okay.
remove all the rolls, all the distortions of the body. That will give you a realistic picture of the defect. Then what I do, I take the mesh first,
Hmm.
violet mesh first. Then I use a junction violet and map the defect.
Hmm.
What exactly is the size? Then you cut back by 2 centimeters from that defect.
Okay.
Okay, so that is the area where I use the bone cement.
I can imagine you
I
doing
got
it.
it. So that is on table. So we learn these things
Yeah.
by by committing mistakes and learning from your.
And how is your rehabilitation protocol, sir, once the patient has been operated? Generally, patients, because of the changes in the respiratory dynamics, may need to be on
Yes,
ventilator if
yes, yes.
it's just for
Uh,
resection.
yes, Shubham. I think massive resections, sternal resections, we go little slow on the extubation. Okay, if there's more than 7, 8 ribs, complex resections, or total sternectomies, we wait for 24, 48 hours at least for the patient to stabilize before we attempt any extubation. And analgesia is very, very important. So that has to be really, I think they have to take a very active part, analgesia. Then we start slow physiotherapy, and especially shoulder girdle diastasis is a problem, especially if you're doing external resections along with clavicle and first rib. So what I do a strapping of the shoulders sometimes, because what happens, the shoulders try to sag back and there will be a lot of stress on the reconstructed part. So I do the strapping of the shoulders also for a week or 2 weeks, and good analgesia, and we try to extubate by day 2 or day 3. Majority of the patients we extubate on the table or day 1. Around 10%, 5 to 10% will require more than 24, 48 hours of ventilation.
And in your series,
And respiratory, yeah, yeah, yeah.
has there even been any infection complications associated with these reconstructions, wherein you may have to take these out prosthesis?
Fortunately, no, for removal. So I've been following these patients. Our maximum follow-ups are now, I think, touching 15, 20%. Till date, I never have to remove any prosthetic material, including bone cement.
Okay.
Maybe I'm lucky, or maybe let's see right now. Yeah.
Ji, sir.
Got it.
Shubham, are there any other questions?
Any questions?
So sir, just last thing that we want, because we have started using now the titanium mesh which the
Okay. Yeah.
neurosurgeons use for the cranial
Yes.
reconstruction,
For the
and we
cranial.
found that
Yeah.
it is easy to
Hmm.
mold according to
Yes.
the contour. It is
Yes.
light in weight. It is
Yes.
remoldable, and
Yes.
it actually acts just like the mesh that we have, much
Yes.
lighter. And
Yes.
the costing, we have found it actually to be very variable, and with a good 10 by 10 centimeter square size, you get for 20,000. So probably the larger ones are the more costly ones, which we find difficult to arrange
Different.
for patients, but the smaller
Yeah.
ones are I think not that bad, sir. So that is why probably we find using titanium mesh actually makes
Hmm.
it so easy for us. It's just like putting a normal mesh and just screwing it over. So
Absolutely. Hmm.
the question that I wanted to ask was actually that I got some feedback that you should fix that titanium mesh with steel
Hmm.
wires. But what we
Hmm.
have been doing is that we have been fixing it with Prolene only. So
Colin. Yeah.
but we
Hmm.
never have had any displacements, because I
Okay.
felt using it with fixing it with steel wires would lead to too rigid reconstruction, and then
Yeah. Yeah.
when the patient will inspire, the rib
Yes.
will not move so freely. So we never use
Absolutely.
steel wires. But
Yeah.
I thought that if you are using a titanium mesh, I could get that feedback that should we
Yeah.
continue doing
Yeah.
what we do, or
Yeah, I think Shubh, your idea is good, but I have not used the titanium mesh for the chest wall as of now. We mostly use it for craniofacials, but
okay.
I think we need to follow your patients how they are doing. That is one idea. Another mesh which is interesting is I am using for breast reconstruction. That is tie loop mesh. It is titanized Prolene mesh.
Okay. Okay.
So that I really don't know how it will work, but I've used as a replacement for a cellular dermal matrix
Hmm.
for doing implant reconstructions. That is called tie loop mesh. It's not very expensive. So one side of the Prolene mesh is coated with titanium here.
Mhm.
It feels like a Prolene mesh only.
Okay, but it's
So
pliable, sir. It's not rigid.
it is pliable. It is available in India. I have been using.
Okay.
We have used in 20-30 cases for the breast reconstruction. I think that needs to be tried. I really don't know how the outcomes will be, but that is available now.
Hmm.
It's called tie loop mesh.
Okay. Okay. We'll find out.
Yeah,
Okay. Sir,
yeah.
Dr. Hari Prasad has asked just one question. What analgesia protocol do you follow, sir? So, would you
Okay.
prefer to get them epidurals with chest wall resections, or just with IV painkillers?
No, most our standard protocol is to go for epidurals in all the patients. We have a dedicated onco anesthesia team and pain team, so they follow all our patients even in the post-op and during physiotherapy rehabilitation. So epidurals normally stay for first week or so, 5 to 6 days. Then we switch to oral analgesics.
Okay. Okay. So, thank you, sir. I think we've had a very interesting session, and I feel that the way your presentation has been is an ideal for to create a short answer. Starting with the types of tumor, the location of tumor, then going on
Yeah.
to the principles of reconstruction, and then principles of resection, and then
This.
reconstruction. So, if somebody is to write an answer, they just need to follow your lecture, make a
Yeah.
short note out of it, and keep it in their copy to write it down finally. So thank you
Yeah.
so much, sir. Thank you so much.
Thank you.
Before you and Dr. Rao go, actually, I want Shubham to get in and tell us the answers of those difficult questions.
Quiz.
So I have the pleasure of having those answers with me, but I want Shubham to explain it to us,
Okay.
especially
Sure. Sure.
especially the trivia one. So just give me a minute till I arrange.
Actually,
Sure.
only the first one was a googly. The rest of the answers were pretty straightforward, and Doctor, they've actually covered them in his lecture as well. So if I can have the questions on screen,
Yeah.
Shubham.
I'm just getting it. Dr. Geeta, are you around? Let me
Yes.
call. Great.
Yes. Yes. Don't get.
Oh,
I think I told Shubham that we did not have a lot of people participating in the quiz. So I think what we're going to do is, start announcing a prize from next time.
Yeah,
No,
yeah.
Dr. Geeta, you have so many senior people that like Dr.
I
Rao and
know,
Dr.
and I think that's the
Dr.
reason why
Ganguly.
we're
They
not
will not.
quiz participants.
And I can vouch Dr. Rao likes to participate in the quizzes for everyone.
I see a lot of stalwarts listening to Dr. Deo,
Yes,
and I
yes,
think
yes.
that's good.
Yes, yes.
That is why you didn't have
Dr.
participation, and
Subramanyeshwar Rao.
1,000 rupees is not
1,000
going to
rupees.
make Dr. Subramanyeshwar Rao participate in that
I
quiz.
know. Maybe we can have a street side party, for all you.
Yeah, that's what we are missing, Dr. Rao. A
Probably
long
here
time.
even I may be guilty for putting in the first question as the most difficult one, which probably deterred. So while I was going through the presentation of the chapters, etc., for chest wall resections and reconstruction, I came across this interesting trivia wherein OCS MRs has been credited with the first chest wall resection way back in 1778. I could not find what he did the chest wall resection for, but that was the first reported chest wall
Great.
resections. The subsequent surgeons have been credited with popularizing and refining the technique of, in principle, the chest wall resection. But the first chest wall resection gets credited way back in 1778. The next question, Dr. Deo very beautifully covered it in his series of how to best utilize the various materials. And he has shown very beautifully the use of all these materials, synthetic mesh, the bioprosthetic materials, and the osteosynthesis systems, all as prosthetic materials for chest wall stabilization. The next question. Sir had also discussed the objectives and principles of chest wall reconstruction. And of these, trapping of scapula is also something that needs to be avoided, especially when the resection involves the fifth and the sixth ribs posteriorly. So along with the other things, this also needs to be kept in mind while reconstructing the chest wall. The fourth question was again covered in Sir's lecture. The most common malignant primary chest wall tumor in adults being the chondrosarcoma. In his series also, I was noting the most common malignant primary wall tumor is chondrosarcoma actually. The last question was pertaining to where we can avoid a chest wall reconstruction. And in these defects that are covered by scapula, small defects so definitely can be left if they are being covered by scapula. But in literature, they've reported that even if the defects are as large as 5 centimeters, they probably can be spared if they are being covered comfortably by scapula and they are not causing trapping of the scapula. So these may not be reconstructed with any mesh or anything. So these were the answers. And Dr. Geeta, would you like to do the honors of announcing who the prize winner is?
Prize with
So
us.
there was no prize winner. So I told you, had Dr. Subramanyeshwar Rao participated, maybe he would have won the prize. But
I actually
out of it.
joined late, Geeta.
Okay, sir, you missed
A
it.
lot of people joined a little late. So, when we
No,
started,
because in the International Society of Diseases of Esophagus webinar was going on. So,
Okay.
I don't know how many webinars you attend in a day. I think if there is a record for the number of webinars
I was the only Indian speaker in that actually. To be.
Okay, great.
Wow, sir.
Great, sir. Great. We missed it.
So the people who answered did not get it right, and they were not even remotely close. So I think we will just not announce it. So maybe the next time. That's what is coming up for you next week. And this, I think, is very, very important. I think, everybody should sit through this and how to critique published literature.
Yeah.
There's a lot of times that we just accept things the way they are served to us and we listen to somebody else who's looked at it carefully and accept that viewpoint. I think, we need to develop our own independent viewpoint. And Dr. Manju Sengar, who's the professor and head of the Department of Hemato-Oncology, Tata Memorial Hospital, Mumbai, will take us through this very, very important session.
So how we have planned is that she will send a paper to us that we are all supposed to read, and then I'll be preparing a quiz on basis of the paper that we have read, and she will go how to, if that is the model paper, how are we supposed to read it. We would also have Dr. Priya Ranganathan with us, who has been taking lecture after lecture after lecture for us. So she has taken 3 lectures at month end for the past 3 months, teaching us, nuances of medical statistics. So she will actually be there telling us how to look into the medical statistics or how to do the sample sizing and stuff like that. So I am trying it to make it more and more interactive so that we don't get bored. And this is actually something that we all should attend, and I hope that we will have a very good attendance at that, because once people ask question, you only realize what you have missed. So having a lot of people would, we are not bothered about stupid questions. We want stupid questions to come.
Stupid questions, yes, they are important.
Yes. So that is why we hope
Yeah.
that we'll have a good thing. But Dr. Manju and Dr. Priya actually agreed, and both of them would be on board with us for next class. So hopefully it will be an interesting one. So thank you, sir. Thank you, Dr. Dev. Thank you, Dr. Rao. Thank you, Dr. Ganguly, Shubham Jain, Dr. Geeta, everybody else for joining us. We will continue to do this thing for the time that we can do till our internet runs out, but we will continue to do this. But thank you so much. We'll come back next week with statistics, and after that probably we'll be back with SBRT for lung cancer. Thank you so much. Thank you, Dr. Dev.
Thank you everybody. Thank you, Dr. Shubham, Geeta.
Thank you, Dr. Rao, and thank you, Shubham.
Thank you, Dr. Rao.
Both the Shubhams,
Yeah, it's a fantastic session. I enjoyed. Thank you, Dr. Ganguly. Thank you, Dr. Rao. Thank you, Dr. Geeta. Good night.
Thank you. Good night.
Thank you.
See you next week.